Hello, we are here today to talk about chapter 12, which covers therapy. So, we are going to do all of these things, but in varying levels of detail, as you're probably used to from me. I'm going to focus on the things that seem most important and relevant to your lives. So, I have some caveats that I want to share here. And I just, as always, your book is always just the starting point for the lecture. And we are always going to do more and different things than your book does. That's why it's important to do both. And we will talk a little bit about some of the things that your book says that I'm not quite in agreement with, just based on my own experience and all of that. And speaking of my experience, I am not a therapist. I have never been a therapist, but I am trained as one. And I've spent a lot of my career um, in and around behavioral health situations. So, most of what I've done is about child welfare, so children in foster care, that sort of thing. And behavioral health topics are very, very close to those topics because pretty much the definition of child welfare includes trauma and challenge and basically needing therapy, right? So I have lots of opinions, and I just want to point out that they're just opinions, right? They're formed from my personal experience and my perspective, and yours may vary. For therapy in particular, this is even more important kind of caveat because there are lots of different kinds of therapy. We're going to talk about that really soon. And though personally, I'm very invested in the evidence base and what has an evidence base, that does not cover near anything that is out there. It's just a very small corner of what's out there. So anyway, we're going to talk about that, and you have to kind of make your own decisions for you. Okay, categories of therapy. So, your book suggests that there's kind of two categories of therapy, which is psychotherapy, which is basically uh, office-based, you know, traditionally you sit down and you talk to your therapist about what's going on in your life. That's psychotherapy. And then non-psychotherapy approaches. Before we do all the psychotherapy stuff, which is the majority of what we're going to do today, we're going to talk about the non-psychotherapy approaches, just because I think that's a nice context, and I have some things that I want to say about that. So, this is one of the things that I don't love about your book. You don't have to write this down. That's what the ear is for. Your book basically says that there are three types of therapeutic providers. I stuck in the word traditional here because I don't love this idea. Psychiatrists are doctors, right? They're medical doctors. They do mainly medication, although there's certainly psychiatrists who do therapy. Social workers and psychologists. So social workers, there definitely is a category of social worker that provides therapy. It's called a licensed clinical social worker. And you know, that category definitely exists, but there's a lot of social workers who don't do therapy. Well, you're listening to one right now, right? And then there's psychologists. And so psychologists mostly do things like testing. So, if you've ever been tested for a learning difference, that sort of thing, that's usually done by a psychologist. Um, you know, therapists come from a lot of different fields, and I'm going to talk about that on the next slide. I'm not sure that I agree that this is like the main set. So also, I just want to point out that this is a very westernized position to take. There's a lot out there that doesn't involve going to an office and sitting down with somebody and talking to them. And what I did here was I made, don't write these down, please. I made a bunch of boxes with some of the options, and at the top you have kind of more traditional options. So LPCs, they are exactly what they sound like. They're therapists, marriage and family therapists, also therapists. You get to psychiatric nurse practitioners, and they have some therapeutic skills, and but mainly it's about medication and stuff like that. Behavioral therapist, that's a specific kind of therapy that only focuses on behavior. So, for example, if you will recall our conversation about applied behavior analysis, that's something that we do with some folks who have autism, for example. That's a behavioral therapist. Art therapists will talk about well, let's talk about it now. So, art therapists where the therapy is art-based, and then you just kind of keep going, and once you kind of get to the middle and the bottom of this, like I'm not even sure what all of these folks do, right? But the point that I'm making is that there is a wide range of possibilities for where you can get therapy. Um, and it does not have to be from, what your book says are therapists, right? That's the point. Okay, so let's talk about non-psychotherapy approaches first. So this is approaches that don't involve, going to an office and chatting with people. So there is a really important nuance here, and I really want to underline it. And I just want to say, so I'm about to tell you about all the ways that you can get help without going to therapy, right? But it does not mean that I don't think that therapy is a good idea or even crucial. You're never going to find me recommending that somebody just not go to therapy, right? That you're not going to find that from me. There is nobody who would not benefit from therapy. Now, what type of therapy? That's a different question, right? But, if you've gone to therapy a couple of times and you're like, this is not for me, well, that's not for you then. That's not the type of therapy that works for you. But there are other options. There's basically endless options for ways that you can get therapy. And therapy is designed to support you in whatever journey that you're on, and we're all on some sort of journey. If we need help with our communication skills, therapy can help you with that. If you need help with emotional regulation, therapy can help you with that. There's all sorts of things that you can work on. And if you think to yourself, I don't have anything I need to work on, then, you're lacking an insight. We all have something that we need to work on, right? So, yeah, that you're never going to find me not recommending that you go to therapy. But, and here's the nuance part. I know that not everybody's going to do that, right? I know that not everybody is going to take themselves to therapy. And because I know that, and because I think that any step that we take towards improving ourselves and becoming healthier is an important one, I'm putting front and center in this lecture all the things that you can do without going to therapy. Okay. And there are, kind of a lot of them. And some of them are still involve some sort of professional, and some of them don't. So let's talk about that. Okay, so one more point. This is the same point, but in a different format. There's a lot of ways to get help. Not all of them are common. So if you've tried to get help and you don't like what happened, there's other options for you. But it's probably easier and cheaper and more effective if you start with kind of the common stuff first. That doesn't mean it's going to work for everybody, but that's probably a really good place to begin, mainly because they're well researched and we kind of understand what the path is. If they don't work for you, you can go to plan B, but I would certainly suggest that that's where you begin. There are alternatives, and I can't talk about them all today. There's first of all, it's a lot of them are outside of my expertise, right? So a lot of the options I know nothing about because I'm trained in this sort of, westernized culture, and my understanding is limited by that. We can try to expand our understanding in our mind, but like there's limits. Okay, so here's some of them. You saw something like this in the Treating Depression Without Medication lecture. That was last week. It's also just kind of out there on my instructional site. If you want to recommend it to people, it can be really helpful. The graphic is slightly different, but here we're going to talk about depression because it's a really good example. And here's a bunch of different ways that you can treat depression without psychotherapy. And that lecture goes into it in more detail, but let's start at the top, the activity, nutrition, and weight. It is very few people who are not improved by increasing their activity level and eating better and managing their weight to the point where they feel comfortable. That does not mean that that's the degree that your doctor wants or whatever, but the weight that you feel comfortable as long as it's not too small, right? Sleep, managing your sleep is really important to mental health in general and can really improve things if you do it correctly. If you go back to the week about consciousness and you did that sleep tracking assignment, and there was a big long video from Dr. Huberman about sleep, that is worth revisiting if your sleep is not ideal. Meditation. So surprisingly, meditation has a pretty deep evidence base. There are specific meditations that have a good evidence base attached to them. One of them is called the loving kindness meditation, which sounds very silly, but is not actually. It's around being mindful of the things that happen in your life that have improved it, and that actually is very powerful meditation. Light therapy, so we talked about this last week as well. There are special lights that you can buy that are especially powerful in the wintertime, that if you're exposed to them for a certain period of time of day, there absolutely is a measurable improvement in mood. This is purely about how our biology works. And, if you recall that chart from last week about the inverse relationship between light and mood. So the less light that we have, oh, sorry, that's not inverse, that's a direct relationship. The less light that we have, the worse mood that we have, right? So more light, better mood. Social support, I think that one is pretty obvious. ECT. So, ECT is obviously administered by doctors. It's electroconvulsive therapy. We're going to talk about this more as we go forward today. So I'm not going to spend too much time on it, but it absolutely is an evidence-based practice. It absolutely does work. Stress management. So huge here. If you're not great at managing your stress, then you're going to have a really hard time managing your emotions. We have a whole module on stress management. So, we're not going to spend a lot of time on that today, but we do have an entire week of the class that is about that. So a little bit of history of the treatment of depression. Again, we're focusing on depression because it is such the most common mental health disorder. And I think it's important to kind of discuss how therapy has, the therapies have evolved over time. So the first use of electricity to help deal with mood was in the 1700s. It became kind of what we understand to be electroconvulsive therapy in the 30s. The image that we have in our head about what electroconvulsive therapy looks like is from those earlier days. You have in your head this picture of somebody convulsing on a bed. It's not like that anymore. The way that it's administered now, like the most that you see is like a twitching foot or whatever. It certainly doesn't hurt. There's no screaming, none of that. That is not that is not the situation. So, like the there's a video on this in an upcoming slide, but the point is that electroconvulsive therapy is the oldest therapy that we have for the treatment of depression and bipolar disorder, which are different, but have a lot of overlap, obviously. And it's still used today, which is really something. So I really don't know how to pronounce this. Isoniazid, I'm not sure. It's an antibiotic actually, and they discovered quite by accident that people who were taking it had improved mood. So, lobotomies. We're going to talk about lobotomies a little bit too, but what I'm talking about here is specifically about kind of the rough lobotomies. So this is where parts of the brain were removed kind of barbarically, basically, in order to affect behavior change in folks. And it worked in the sense that you got a behavior change. However, it worked because you removed part of their brain and they basically are no longer the person that they were, right? That's a bit throwing the baby out with the bathwater, I think. But again, they had very limited ideas about what to do. So lobotomies, yeah, not great. So tricyclics come along in the 1950s. These are medications. They're not ideal for a myriad of reasons, which we'll talk about when we get to the medication slide. Prozac is the first selective serotonin reuptake inhibitor, SSRI, comes out in 1987. It is very safe, and it basically changed everything about how we treat depression and has basically heralded in the modern version of treatment for depression. The last 35 years have looked very, very different for depression treatment than in the span of history before. Okay, so this is a really great time to take a break from the lecture, go back to the page, and watch this video about ECT while we're thinking about ECT, and then please return to the lecture. All right. Okay, so let's talk about psychosurgery a little bit. So lobotomies are the original, the OG psychosurgery. And Rosemary Kennedy, who was President Kennedy's sister, I believe she had Down syndrome and a few other issues. And she received a lobotomy, I believe in the 60s or the 50s. And for some, because it's a high profile family, the Kennedys, it became public knowledge when at a time when lobotomies were really not discussed. And it really raised awareness in the culture around lobotomies. And honestly, like it did a lot for making this practice go away. It took a few decades for it to really go away. But this was a really important turning point. Like I said before, they do work, but only because they have caused so much damage that the brain no longer works. So that's not really an acceptable trade-off. I will say that their psychosurgeries do still exist. There are some that are in use that are really effective, right? Mostly for obsessive compulsive disorder, which is a very, very biologically based disease. But also for depression, there's a psychosurgery that you can get that implants electrodes into your brain for deep brain stimulation. This is essentially like portable ECT, basically, right? So the electrodes stimulate your brain. I'm not really sure if it's on a schedule or you have to go to the office, or I'm not really sure, but they're implanted in your brain, and that is how your depression is managed. So it's not so much that the surgery is the treatment, but that the surgery, enables the treatment. Okay, so the medications. So, antipsychotics, remember, we're talking here about methods for therapy that is not psychotherapy, that is not talk therapy. Okay. So antipsychotics are for people who, surprise, surprise, are experiencing psychotic symptoms. And there are several generations of antipsychotics. The original ones, like Haldol, for example, very sedating. Think lobotomy without the surgery part. And had a lot of really ugly side effects. And you know, since that original version of antipsychotics, we have had a couple of generations of new antipsychotics that do not have that effect. And they will treat all the kind of positive symptoms. If you recall how schizophrenia works. There's positive symptoms, which are like delusions and hallucinations, things that are added to your lived experience by the disease. And then there's negative symptoms, which are things that are missing, like motivation, that sort of thing. Antipsychotics really focus on those positive symptoms, so delusions, hallucinations, that sort of thing. Schizophrenia really is about dopamine, and they work by blocking those receptors. So anti-anxiety meds kind of fall into two categories. That's why there's a little star here. The anti-anxiety only, we'll talk about antidepressants and anti-anxiety in a sec, but the anti-anxiety only, we're talking here about benzodiazepines, right? So that's like your Ativan. Right. So these medications are for people who are having some sort of acute um experience. It's not to say that there are not people who take Ativan regularly outside of having an acute experience of anxiety, so like an anxiety attack, that sort of thing. However, it's not a great idea because they are highly, highly, highly addictive. Benzodiazepines are some of the most addictive medications on earth, and you are best advised to be very careful about when you take them. So if you're having a panic attack, by all means, take that Ativan. But if you find yourself being like, you know what I'm going to take right now? I feel a little anxious. I think I'm going to take a benzo. Don't do that. Seek assistance, right? If you're finding yourself thinking in that way, the addictive properties are really acute. So I mean, keep them around for sure. Like I have a couple of Ativan, about 10 feet from me that are used for dentist, right? So like that sort of situation, totally fine. But you should not have a full bottle that you're taking, every day, multiple times a day. That's not good. Antidepressants. So antidepressants treat depression and anxiety. Some are better than others at treating anxiety, but for the most part, SSRIs are used for both. And this is because if you'll recall from last week, recall the slide with the coin on it. Depression and anxiety are just two sides of the same coin. They're essentially the same disease and have the same treatment profile, except anxiety has this sort of added um, acute kind of possibility to it. That's the panic attack, right? Um, so anyway, the SSRIs will treat both. The issue about the old antidepressants. So MAOIs and tricyclics is basically they both can kill you, right? It's not that we don't still use these, but the possible side effects but behind MAOIs and tricyclics are potentially lethal. So, overdose, for example, is a real risk, and it's very tricky to get the dosage correct on these. And you can see the inherent problem with giving people who are depressed medication for being depressed, that if you overdose on it, you can kill yourself, right? So you see the problem. So, we don't use these much anymore. They also have drug interactions and in some cases food interactions. So we don't use those much anymore, but if you have treatment-resistant depression, this is certainly an option for you. Okay, so now we're at psychotherapy. So I'm going to talk about individual adult psychotherapy for the rest of the lecture, basically, but I want to touch on these other forms of psychotherapy because there's a lot of myths out there about these types of therapy. So let's talk about play therapy. If you do not understand fully how children develop, um, you may take your child to play therapy and think that they're not doing anything, that they're going to the office and they're just playing with the therapist and nothing is happening. However, play therapy really is designed to understand that children, and even some adults, honestly, do not have the capacity to put their emotions into words and to discuss their emotions, right? So young children are basically just not able to verbally articulate what's going on for them. And so play therapy utilizes something that children do already to tease some of that stuff out. So the play therapy techniques are really designed to help the children um, expressed to the therapist through drawing or through doll play or whatever it is that might be going on for them. And then, let's say the therapist is, playing dolls with them, and then the therapist will, deal with whatever has come out in the context of that play session that they're having. So it looks like sort of standard play, and that you would have with your children at home, but don't mistake it for that. It has a very directive, evidence-based purpose. Group therapy is usually something that we do in conjunction with individual adult therapy or for youth. They have to be of a certain age. It is very cost effective. It can help build a community among people who are having similar experiences with their mental health and reduce isolation. Really good there. It's not for everybody. If you are somebody who's experiencing a lot of social anxiety, group therapy might not be for you. Um, it does sort of involve a commitment of time, and this is a very if it's not being conducted by somebody who has a lot of training and experience in how to conduct group therapy, it can go wrong fast, right? So that there's a lot of rules around what can happen in a group therapy session, like a lot of shared agreements about who talks when and how they talk to each other and all of that stuff. And it takes a skilled therapist to enforce that well. And it also takes people who are willing to engage with those groups, right? So, with those rules. So it can be a little bit tricky, but this can be a really useful tool in the box of tools that are for any one person, right? I would not suggest that group therapy is great on its own, but when you are combining it with other things, it can be really useful. And it has like a sister concept, which is the support group, right? And the difference between group therapy and a support group is that group therapy is led by a therapist, and support groups are not. They're generally led by peers. So family and couples therapy are really the same thing. They have the same purpose, and that purpose is to improve communication between either the couple or the family. And I think it's really important to kind of point out that it's not about identifying who's making mistakes. It's not about that. It's about identifying who is what the patterns are, what the communication patterns are, and improving those so that people can understand each other better. I really hope that that kind of makes sense, because it's a really important concept to understand about how family therapy works, and why, people are generally so resistant to it is because they think that it's about blame, and it really is not. It is about communication. I also want to point out that if family or couples therapy is not available to you, for whatever reason, it's expensive, it's not covered by insurance, whatever it is, John Gottman, I'm just going to put in a little plug here, is a renowned couples and family therapist, mainly couples, um, in this field for decades, has done lots and lots of research into what sits behind marital problems specifically. He's written a lot of really good books for lay people about how to improve relationships and marriages and all of that stuff. So if this is not available to you, but you could benefit from some improvement in your couple's relationship in particular, I highly recommend that you go find John Gottman books. There's one in particular that I was actually assigned reading in graduate school. That's how good it is. Called, I believe it's the Seven Principles of a Strong Marriage, or something along those lines. Really, really excellent book. So that's my plug for John Gottman. So e-therapy is kind of new on the scene, right? So this is therapy that you get over video or call or text or whatever it is. And, like maybe it's as effective or maybe it's not as effective as going in person. But the point is that it has improved access to therapy for so many people. If you don't have the time to drive to an office, or you don't have the transportation to go to an office, and it's often cheaper than in-person therapy. If you are not, if you don't have the mobility to go to an office, that sort of thing, it's really important innovation that has helped a lot more people access therapy. Okay, individual adult therapies. We can't talk about therapy without first talking about Freud. So again, here we are back at Freud, right? So his main theoretical core is that psychological problems are really coming from an unconscious forces most of the time, right? Okay. So, when we think about therapy, usually what we're thinking about is centered around Freudian psychodynamic principles. So, if you have in your head the person laying on the couch, facing away from the therapist, and the therapist is sitting behind them with a pen and paper and just nodding, you are thinking about psychodynamic therapy. And this type of therapy is um, it's very insight oriented. So it's really about the person coming to their own realizations about what's going on. There typically is not a whole lot of feedback from the therapist. That the stereotype is that the person is just talking and talking and talking until they come to some sort of light bulb moment. It's not quite like that, but it's in comparison to other therapeutic approaches, it is more hands-off by the therapist than others. You do not see a lot of psychodynamic therapy anymore. This was the original type of therapy, so we can't like discount it, but you just don't see this much anymore. First of all, it is extremely expensive. Psychodynamic therapy is not something that you do 1 hour once a week. It is something that you do several times a week or 5 days a week, and that becomes very expensive. You have to think about the type of people who can afford that. And also, it doesn't have an extremely strong evidence base. There's not a lot of proof that this really works all that much beyond the catharsis of being able to talk about how you're feeling, and the emotional improvement based off of just that. Beyond that, there's not a lot of evidence that, the way that this is done is really useful. So there's not a lot of psychodynamic therapists left. And it's kind of a niche type of therapy. But again, because it was the first type of therapy, we really can't go forward without talking about this first. There were some really important ideas that came from psychodynamic therapy. I've already talked about catharsis. Transference is about how the client puts emotions onto their therapist. And I can't emphasize enough that transference, countertransference, and resistance are all normal therapeutic processes. Okay, so it is 100% normal to experience emotions that you're putting onto your therapist. So, for example, a lot of people think that they're falling in love with their therapist. Well, you can't fall in love with somebody you don't know, right? The whole idea behind the therapist client relationship is that the therapist knows a lot about you, but you don't know almost anything about the therapist. This is not like a friendship conversation. It's not a back and forth. You don't have to put in as much as you get out. You don't have to get out as much as you put in. That's not the situation, right? You are paying somebody to listen to you, and you're not paying them so that you can learn about them, right? So that's not to say that there are not moments where disclosure is important. There's certainly, those moments exist, and it is, and all of that. But by and large, we don't know that much about them. We certainly don't have that sort of back and forth relationship. And so you can't really be in love with your therapist because you don't know them. But it's normal to feel like, hey, this is a safe space, and I'm pouring so much of myself into this relationship that now I have emotions attached to this person, and that's normal. And that's part of the conversation between you and the therapist, but it's just really important to understand that this is a therapeutic process, right? This is not a problem. That just means that you are starting to really engage and trust in the process that you're in. Countertransference is also normal, but is a little bit more complicated. And this is about the therapist putting emotions onto the client. And the reasons are a little bit different, but the bottom line is the same. So the therapist is listening to all these things, and they're getting to understand how this person thinks and is in the world, and they can develop emotions around that. They're people, right? Therapists are people. And you know that is normal also, but we have to be careful for the same reason, right? Like, so the relationship is not a back and forth. It is not a give and take. And so you can develop emotions, whatever they happen to be, but they're not based in a relationship that the two of you have together. So, countertransference is something you don't really talk about with your client. It's something you talk about with the person who is supervising you, which is part of why supervision is so important for therapists. Resistance, totally normal, right? So this is a pushback basically of the client who does not really want to engage, and the way that they push back is they cancel or they, move away from things that make them uncomfortable or whatever it is. But that's kind of how you know you're getting to something important, when people really start to resist. Okay, so we're moving on now from psychotherapy or from psychodynamic principles into behavior therapies, right? It's complete other end of the spectrum, right? And this is really not about your emotions at all. This is they address your emotions indirectly, but it's really about changing your behavior, right? This is really about just about what you're doing in the world, and making it more functional. So counter conditioning really is pairing the anxiety-inducing stimulus, so whatever is making you anxious, with something that calms you down, and that will weaken that negative response. So, we have some examples in the idea that, let's say that you are afraid of dogs, okay? But you're very comforted by your rosary, right? So if you pair a dog with your rosary, right, you can weaken that anxious response. Now, it's like not the best example, but you get the idea, right? And by pairing these two things together, you learn to calm yourself down because you associate calm with the second thing. So, response prevention, this is basically like you are prevented physically from doing whatever the thing is that you really want to do. This is mainly about compulsions. So people who are compelled to, for example, get up and check the stove, right? Make sure the stove is off. You're prevented from doing that. You cannot get up and check the stove. It does work. It's really hard on you, right? If you think about the compulsions that you have, and everybody has a compulsion, right? Or has had a compulsion at some point, like where you feel like, oh, I really need to do that. I really need to check that. And really need to, like, just make sure that that is the way that it's supposed to be. That, if you've ever hit the alarm on your car 15 times or something just to make sure that it's locked, or, the uh, the going back upstairs to just double check that your door was locked or something when you never forget to lock your door. Like, if you think about the anxiety that pushes you towards that compulsion and how you feel after you've checked, right? um and then being prevented from doing that, right? If somebody says no, you can't go upstairs to check that the door is locked, you just have to go on this 2-week vacation with that question mark hanging in your air and in the air, then you can understand how anxiety provoking this can be. But it does work eventually, so it's not for everybody, right? And then these other two have their own slides. So desensitization is something you can actually do for yourself. You don't need a therapist to do this, but the underline that I want to make here is that you absolutely have to do these things in the order that I've presented them. So you have to learn how to systematically relax your body. So a lot of us did this in school, where like somebody would walk us through a guided meditation where first you would relax your toes and then relax your feet and then relax your lower legs and so on and so forth, right? And you must learn how to do that first, and then you have to learn how to do it quickly, right? And then you can begin on the list of the scenes that are inducing anxiety for you, because the way that you're going to deal with these things is by doing that systematic relaxation. So, you've learned how to do it, and then you sit down to imagine seeing the snake. You experience the emotion around it, the anxiety around it, and then you mindfully, systematically relax your body until, and you do this over and over and over again until that imagination of seeing a snake does not cause anxiety at all, right? And then you can move to the next step. You can do this fast or you can do it slow. It kind of depends how effective that systematic relaxation in your body is. But this can take months or years or whatever, but it does absolutely work. And no, you do not need a therapist to help you do it. You just need to learn how to systemically relax your body. And you can download off of YouTube or something, um, guided relaxations that will help you do that. This is a DIY that you can do, or you can hire somebody to help you, right? But you can certainly do it yourself. Okay, so let's talk about aversive conditioning. This is just an example. Alcoholism is a good example. I do want to point out, and this came up in the in-person class, that this type of aversive conditioning is also used to try to make people not be homosexual, right? Those therapy centers do still exist, and I use therapy in the loosest possible term because that's not therapy, it's basically abuse. But like, these are the principles that are used in those conversion centers that are supposedly there to make you not gay anymore. Same principles. And then we'll explain why it doesn't work, right? They don't work. And here's why. So, if you will recall from the learning chapter, the UCS is the unconditioned stimulus, and then the UCR is the unconditioned response. So basically, these are things that you don't have to learn. You drink the alcohol, and the result is that you are pleasantly intoxicated, right? That's not a learned response. You don't have to learn that. That just exists in the world because that's how our bodies work. Fine. So in therapy, right, you are trying to short circuit that by taking a medication, right, that makes you feel nauseous when you drink. So now we're in the little B box here. And the unconditioned stimulus is the alcohol, and then the idea is that you take that medication, which is also an unconditioned stimulus, and then the response is that you feel pretty gross, right? And the idea is that afterwards, that conditioned stimulus, because now we've conditioned it to be paired with the nausea, right? That whenever you kind of think about drinking alcohol, you feel nauseous, and so you avoid it, right? So this is the theory. It certainly works while you're doing the therapy. While you're taking that medication, it 100% works. But the problem is what happens after therapy. Punishment is not powerful on its own. And the reason why punishment is not powerful on its own, okay, is because it only works as long as the punishment is active, right? So the core issue here, and the core issue with conversion therapy, is that the intervention only works while it's happening, because if you go back to A at the top here, this is an unconditioned stimulus and an unconditioned response. Once you stop taking that medication, okay, eventually this nausea is going to fade, and your body is going to remember that, hey, these two things paired together, the alcohol and the intoxication, that relationship exists. And unless you are actively preventing it, with that punishment essentially of the nausea, then it's just going to reassert itself pretty quickly, right? So, this concept of punishment is not powerful. We've examined that over and over and over and over again in this course, right? It is much less powerful than reinforcement, and we'll talk about that quickly soon. But um, it just that's why aversion therapy just doesn't work. It just doesn't, because these are unconditioned stimulus and unconditioned response. It's always going to be there unless there's a barrier in front of it. Okay, so again, about reinforcement. So behavior modification, on the other hand, something that is based on not punishment but reinforcement, is a token economy, and we've seen this before, right? So like the technique uses reward, sometimes punishment, but mainly reward, to modify behavior, and it can be used with groups pretty effectively. If you'll recall this image from before, right, the reinforcement has a downside, right? It can damage intrinsic motivation, right? We've talked about that when we talked about motivation. So how do we do it right and preserve that motivation? Well, if you will recall from that lecture, the rewards, they need to be precise. They need to be yoked to specific performance standards, which might include outperforming others. So that's your athletics, right? Um, and they need to be really powerful, but avoid tangible items when you can, right? So when the reward is heavily material, you are at really strong risk of turning that internalized motivation external, right? So when you start paying people to do work that they otherwise enjoy, then you are in a situation where you have created their motivation to be external to them. It's about the money now. It's not about the enjoyment of the experience. And so we really dismantle that motivation when we do it like that. So we really need to create rewards that convey that the person really is in charge of what happens to them. And, it's more about their emotional enjoyment and the support of being praised, more or less, than it is about like, oh, you did what I wanted you to do, so here's a pile of money. Okay. So shaping, observational learning. So there's kind of two important points about observational learning. Modeling is I'll show you, and then you'll become more involved as you become more confident in the thing that I'm showing you. The picture here, this is my daughter and my horse, and she watched me do what she's doing in this picture many, many, many times. And and then I got to the point where I was helping her do it, right? So she had seen me do it lots of times, and then I was helping her do it, and then she's doing it on her own, right? So that's modeling. Social skills training is mainly about, well, social skills, right? So this is about, I'll show you the right way and the wrong way, and then we'll talk about it, and then you'll try it, right? That's basically what social skills training is. And if you are interested in going into social work or being a therapist or anything like that, you should get used to this, because you'll be doing a lot of it in graduate school while you're learning about how to be in a therapeutic space with somebody. All of those role plays are basically social skills training, right? Okay, cognitive approaches. So cognitive therapies are really about identifying and then modifying your patterns of thought, right? And thus your behavior in the world. Okay. So there's different kinds of cognitive therapies. Um, we'll talk about kind of why the distinctions between them are not super meaningful in a bit, but here's three kinds of them. You know, if you are somebody who kind of flies off the handle when you have a negative experience, then acceptance and commitment therapy is probably, good for you. Rational emotive behavior therapy is for the more analytical among us. This is where, your beliefs are challenged by the therapist, and you're basically argued into understanding that, like, oh, what you have in your head is not accurate. And so here's what the evidence is. The evidence is, that you are not, bad at your job. The evidence is that, the finances of the department required that you were laid off, right? So that type of thing. Cognitive behavior therapy, I put a little ribbon on this because this is like the most um, widely used type of therapy out there today, and it's got a very strong evidence base to it, right? And the idea behind cognitive behavioral therapy is that it identifies and changes that negative thinking and the negative behavior, right? So it's basically you take that rational emotive behavior therapy, and then you add a behavior component to it, and you have very basically cognitive behavioral therapy. So, um, this is a good time to go watch the video from Dr. Beck, the father of CBT. So if you could pause this lecture, go watch that video, and then come back, that would be really helpful. So I'll just wait for that. Okay, so welcome back. The idea of this approach is basically that, he this is a little bit apocryphal, right? His video here where he explained this process, this is not something we actually do in one session, right? Like, he's explaining it like you sit down and you do this in one session, and that is just not the case. Like, that's just not how this works. And it's not as simple as he made it sound, but the point that he's trying to make is that this is kind of the process. And the process is very much like a kind of a gentle challenge of, like, are you sure that that thought process represents what's really going on here? And, the kind of the outcome of that. So yeah, it's not exactly as he described it, because he was trying to condense it, basically years worth of therapy into a 5-minute conversation with some students, but you get the idea, right? So the humanistic approaches are, kind of the ones that help people really get in touch with their emotions, right? And we've seen these principles before, right? So the client-centered principles of conditional and unconditional positive regard, like, the idea here is really about you're now in a space in therapy where you are being where you can experience unconditional positive regard, right? For a lot of people who end up in therapy have never been in a situation where they experienced unconditional positive regard. They were raised by a family that required that in order to be loved, that you perform this or that or the other thing. And if you don't, then you're not loved, right? This is pretty common lived experience for people, but it's a hard one, right? Because it causes all sorts of emotional problems for people. Um, and so in client-centered therapy, you are existing in a space where you are regarded positively regardless of what the circumstances might be. And he's gonna, when we get to the slide about that, he's gonna talk about that in his video. Gestalt therapy, really interesting. It's pretty directive. It's much more active on the part of the therapist than many other types of therapy. I do want to point out that there's a really useful technique in Gestalt therapy about the empty chair. And it's basically, um, And it doesn't have to be a chair, you can, it can be a table, whatever. The idea is that you are picturing the person that you want to talk to in the chair, and then you tell them everything that you have to tell them. And, by the process of catharsis, basically, you're feeling better after you have a chance to do this. Again, you don't need a therapist for this. It does work. It feels a little dumb at first, for sure, but it does absolutely work, right? Because getting that stuff out, putting it out into the world, into the universe, totally helps us process. So, this video is Rogers talking about the kind of unconditional positive regard. There's a little bit of history here that you need to understand about the South African Army. I'm not going to go into too much detail about the politics of the situation, but understand that being an officer in the South African Army and the time period that he's talking about basically means that you have committed all sorts of atrocities for and towards, marginalized people. So that's what he's talking about in this video, about how he had to, kind of rearrange his thought process in order to provide this person with unconditional positive regard. So if you could go watch that video now, that would be great. Okay, so we're pretty much at the end here, but I just want to point out that the bottom line about therapy is that, the most important part of it is the therapeutic alliance. It really is mostly about the relationship between the therapist and the client, right? So Rogers, in the last video that you watched, really covered this, and really kind of explained that therapeutic change comes from this place. But this is definitely an evidence-based theory, right? That the therapeutic alliance is critical to success, and it really is. Without that, the client doesn't feel safe, they don't feel seen, they can't do the work, they can't focus on the work. So that therapeutic alliance is really, really critical. I also want to point out that it is really uncommon to find a therapist these days who is purely a Gestalt therapist, or, purely anything really, because most therapists are trained and to do a mix of techniques that work for them and their clients. Like therapists are individuals, clients are individuals, and it's pretty uncommon to find somebody who is hands down, double down devoted to one approach, except maybe, the psychodynamic people. And just are not that many of them left for exactly this reason. And it's more about being present with the person that you're doing the work with, and giving them the techniques that will work for them in any given moment. So, for example, the empty chair technique is not a cognitive behavioral therapy technique. However, you can see how they're compatible, and you can see how it would be useful in a cognitive behavioral, therapy session kind of situation to sometimes do that. So, therapists have a tendency just to put together what is needed in any given moment, and that's kind of what we want, right? All right. So if you have any questions or anything like that, I am absolutely happy to answer them. Just let me know.